Hey class, it's Dr. White. We're going to be doing an introduction to addictions video today. Some of the topics that I'm going to discuss in this video are what's the difference between a habit and an addiction, and also what's the difference between mental health counseling and addictions counseling. So go ahead, pause the video, grab a piece of paper and a pen so that you can jot down some notes for your discussion board this week. And what we'll start out by, I want you to think about what is an addiction versus what is a habit. So some of the behaviors you want to think about are possibly gaming or gambling, shopping, working. Can you be addicted to work? Can you be addicted to shopping? Can a person be addicted to gambling? Some other behaviors are, what is recreational use versus abuse of a particular substance? And does it matter what the substance is? If the substance is sugar, if the substance is nicotine, if the substance is methamphetamine, does that make a difference to how much you can use, how frequently you can use, and for what duration of time you're using that particular substance? And how does that impact whether it is a habit or whether it is an addiction? So typically when I tend to think of what is the difference between each, a lot of times some of the questions that we ask in addictions counseling are, what's the age of onset, meaning when's the first time that they used? What's the duration of use? So when did they start to when is the last time that they used? Frequency, how often do they use? How many times a week? How many times a day? And the amount of use. So drinking 1 beer a day for 3 years versus drinking 4 beers a day for 14 years. And then also, how are they consuming the substance? Because are they snorting lines or are they injecting? Because that makes a difference to how quickly the person gets high, how severe the addiction is, etc. So when we used to classify addiction, it used to be either they are abusing a drug or they are dependent on the substance. Now that has changed a little bit with the newest DSM, and it's very similar or more similar to how we diagnose other mental and emotional disorders. So if we have depression, we have either mild, moderate, or severe. If we have anxiety, it's either mild, moderate, or severe. So what they've done in the newest DSM is they've changed the addiction from abuse and dependence and made it alcohol use disorder, mild, moderate, or severe. Cocaine use disorder, mild, moderate, or severe. But you will still hear a lot of that old terminology used, specifically in treatment centers that have people who were trained under the previous DSM. And some of that language just kind of sticks around. So being aware of that. But going back to what is a habit? Can a person be addicted to working? Can a person be addicted to shopping? Are these things that equal an addiction status? Or is that a person's bad habit and just needs to change? Does their age make a difference? Does, like I said, the frequency, the duration, etc.? What impacts how you think of addiction versus a habit? So what research shows is when you tend to think about addiction versus habit is something that is done for convenience sake. So it is a behavior or something that you do based on convenience. When it gets to an addiction level, it has a negative consequence on the person's life, but that doesn't stop the behavior. So even though I've been arrested 3 times for DUI, I'm still drinking and driving. So I've had the negative consequence. Like, yes, it was more convenient for me to drive rather than maybe call an Uber or something like that. So we could see how that could be a habit. But once it starts having those negative consequences and impacting your life in a negative manner, and you continue the behavior even with that negative consequence, that's where it seems to go over this hill of, okay, we're at a habit, but then we go to addiction. The interesting thing about the DSM that you all are probably using, the newer DSM, is that it is much easier to get an addiction diagnosis now. So before you used to have more criteria to meet the diagnosis criteria. Now they've lessened that. So they have 11 questions that you ask a person about any substance. The questions remain the same. And if they have 2 of those, then they have use disorder. So blank, whether it's cocaine, methamphetamine, steroids, nicotine, caffeine, whatever it is, use disorder, mild. That's if they meet 2 of the criteria, which are really easy to do. And a lot of people didn't like this because they thought we were overdiagnosing. But I think, or what the research says, is why this change was made. It was because we believe that the earlier we intervene in the addiction process, because a lot of people believe this disease model. So the longer that you have a disease, it gets worse and gets worse without treatment. So the earlier we intervene, the more likely we are to be able to prevent long-term use. So if we have less criteria to meet that, then we can intervene at an earlier stage, specifically when it comes to adolescents and youth who use substances or have addictive behaviors. So when you're thinking about that, that's one thing I want you to think about between the habit and the use. The other thing that we kind of want to discuss is what a lot of people talk about is, well, what's the difference between mental health counseling and substance abuse counseling? So some of this will come out when you're reading your text, and you'll learn a lot about the history of addiction and the models of addiction and the treatment and, different things. And a lot of it does have to do with the history, which I could do many videos on the history, and we won't go there today just for time's sake. But when you're thinking about mental health counseling versus addiction, they used to be seen as 2 very separate entities. So I worked in community mental health, and I would have people come to me maybe for depression and say they were actively using. Then we might send them over here to get treatment for their use. So I'm treating them for depression, but this other agency is treating them for their addiction. And it was seen as 2 separate places. But a lot of times they're so intertwined that we're started to realize, or maybe the field finally, caught up to understanding that they're so intertwined that why are we separating them? So a lot of that goes back, like I said, back to the theories and the history, and thinking about like what causes addiction. So we don't have a cause of addiction, even though different theorists believe different things. So back in history, we talk about a moral model, or people who use, a lot of times it was thought to be a sin, or maybe, a bad spirit had a hold on them, or they were just bad people, sinning people. So they call this more of the moral model. And that's what the correction system, or detention system, jail, etc., that's the model that they still kind of work under, is let's punish a person for use and then they'll stop using, which we know hasn't worked. I mean, we've been doing that for about 100 years now, and it hasn't worked because people are still using, and even at more alarming rates. So then it goes on to other models, such as the psychological model, when this is maybe I've experienced some kind of trauma, and instead of dealing with those feelings, I will use a substance so I don't have to be in those feelings or be present in that moment. So that's more of that psychological component. Or maybe I have anxiety. I hear this a lot from clients is, I was really anxious and I feel better if I smoke weed. So they're using, or they're self-medicating with cannabis to reduce their anxiety. So then that goes to what came first, the anxiety or the cannabis use? In the example I just shared, it was the anxiety, and they're treating it with cannabis. So if we treat the anxiety, then they won't have a need for cannabis use, and that disorder will go away. So that's where, when you're thinking about mental health versus substance abuse counseling, there's where some of that started to get really sticky. How am I going to treat the anxiety and hopefully the substance use will go away, or vice versa? So say maybe the client wasn't anxious. Maybe they've started using methamphetamine, and then they start to become very paranoid, very anxious. So when they come to counseling, they're talking about all of this anxiety and all of this paranoia that they have, and maybe even hearing some voices or things like that. Well, is that related to chemicals in the brain? Is that related to anxiety, or is that a side effect of the substance they're using? So I could give them an anxiety diagnosis, or maybe a mood disorder, or whatever they're presenting with as far as symptoms goes, but is that actually correct, or is it the substance that's causing that? And that's what makes it really interesting when you're working with clients who have co-occurring disorders. That's what we call it when clients have both. Sometimes you'll hear the term comorbid. Right now, the current term is co-occurring disorders. So we're starting to think, we as the profession are starting to think, okay, maybe they aren't two separate ideas, and it both impacts the brain, it both impacts behavior, and we don't know what comes first. It's like that whole chicken or egg argument. Is it the anxiety that came first, or is it the use that caused the anxiety? And a lot of times clients, maybe don't have that information or can't remember that information, or they start using at such a young age that we don't really know. If they started using marijuana or drinking alcohol at age 9 or 10, how much do they remember about their anxiety when they're 9 or 10, but they're seeing you in session maybe when they're 45 years old? So a lot of that's kind of hard to trace. So we want to treat both of them just to give them a better quality of life in general. Now, there are differences in some addictions treatment and mental health treatment. A lot of times addictions treatment uses a lot of abbreviations. They have IOP, which means intensive outpatient. When I worked in community mental health, clients would typically come in 1 or 2 times a week. And then as they improved, maybe we could do once every other week and then once a month. And then, once they were in maintenance stage, they could go out back into the community. However, if it's an addictions client, depending on how severe the addiction is, the client might need to go through detox. They might need hospitalization or partial hospitalization. If the client's pregnant or has other medical issues, that could become an issue. And there's certain substances that if they quit immediately, they could die. So 2 substances that happens with are alcohol and benzo. So if they go cold turkey from certain substances like alcohol, if you say just quit cold turkey, that can be very dangerous. Typically with mental health disorders, you don't have as much as that. Obviously, if they stopped having depression symptoms, that's not going to harm them by not having the symptom. Not having alcohol could technically harm the client if the addiction is severe enough. So there's level of treatment, which you'll learn a lot about in the upcoming weeks. And when we're talking about that, some of the diagnosis stuff used to be very different because it wasn't on mild, moderate, or severe, but the field has kind of changed that, and we're going more so that they align. The other thing that I think is different between addictions field and the mental health field, one of it's training. Do you have the training to work with people in addictions? And I think that's very important, obviously, why you're taking this class, but also just thinking about, I lost my train of thought now. I'm sorry. The different models, the neurobiology, the classifications, ethics and culture are the same. Some of the assessments are also different. So you might have the Beck Depression Inventory if you're going to assess for depression, or the anxiety inventory, those sorts of things as far as assessment goes in mental health, but for addiction, they would be different. Also, a lot of people who come for addiction services are mandated clients, and many times have legal ramifications. So a lot of times confidentiality might be different because you might receive a court order or have to release records to maybe a probation officer, etc. Because a lot of times treatment is combined with some kind of legal consequence. So that can make it a little bit different. I still don't remember what the other thing I was going to say. So some of the other things are, we talk a lot about relapse prevention. I remember now. So it's stigma. The stigma between mental health and addiction. So I can come in for mental health services and I can say, I'm having some depression. I cry every day, hopelessness. It's impacting my sleep. It's impacting my eating, etc. You're not going to say, okay, well, before I see you the next session, you have to have no symptoms and then you can come back and get treatment. If I come to you with anxiety and say, I'm restless, I have pressure in my chest, it's giving me headaches, I'm grinding my teeth at night, I've, picked my skin to the point where I have blisters just out of anxiety, I fidget a lot, I can't concentrate, etc. You're not going to say to me, okay, well, once those symptoms are gone, then you can come back and get treatment. But with addictions, what happens is the client possibly comes in, and if they're actively using, so maybe this morning I drank 3 beers and I smoked a blunt. We oftentimes won't see the client because maybe they're not clear-headed enough to sign a consent, etc. But we want them to stop having those symptoms, which is the use, before we will see them. So that's another kind of ethical dilemma, I guess, which you'll learn about in future chapters, just talking about the ethics. So there is a lot of stigma, I think, with mental health and addiction, but addiction also carries that legal component and the component of, I don't want you to have the symptoms while you're in treatment. Whereas mental health, they can have the symptoms in session, be crying, be depressed, be anxious, be fidgety, and we're not going to turn them away at the door. We're just going to either increase treatment or continue treatment. And that's not the case with addictions. Oftentimes, if they do relapse, have a craving, do have a relapse, then they can get kicked out of the treatment program, and those sorts of things. So that's just something to think about as well. So that gives you a little bit of background on the difference between mental health counseling and addictions counseling, and also what makes something an actual addiction versus a habit. Some of the other stuff that you talk about in your introduction chapter, or in the first few chapters, like I said, is the history of addictions, the different models, some of which I discussed in this video, also the neurobiology and the physiology of addiction and kind of what that does in your brain, that reward center, the neurotransmitters, etc. Now, this is becoming a huge topic in the counseling arena, so I want you to pay attention to that chapter. But the thing is there's no way to really measure that except for the client's reporting, or from a legal history or something like that. But that is very important when you're thinking about the difference between a habit and addiction. Do all habits become addictions? Can all people get addicted? Just some questions to think about this week while you're doing your reading. Also, the book will talk about commonly abused drugs, different drug classifications, different behaviors. I mean, right now you'll hear a lot about sex addiction, but it's not actually in the DSM. Only gambling is. There is some reference in the DSM about gaming. There's a lot of research on gaming addiction going on right now, so we might be seeing that in the next DSM. And some people think eating disorders should be part of the addiction, or hoarding should be part of addiction. And kind of where do you classify those things if you have compulsions to do something? So is a compulsion and a craving the same? Other things that we'll cover in this class are ethics, culture, competence, some of the best practices, assessment, diagnosis, treatment. I talked a little bit about co-occurring disorders. You'll talk a lot about, or you'll read a lot about, relapse prevention. Also special populations. There's a chapter on different special populations, whether that's children and adolescents, geriatrics, women, people of color, LGBT. I'm pretty sure that I've uploaded some videos on Native Americans and alcohol use, and just the research there, and just some very interesting videos that I have for you later in the term. Other things that I want you to think about, and then we'll end this video. So one, think what puts people at risk to use. So from the age of, let's say, 6 onward through life, what puts somebody at risk? Also think about, is there such thing as a gateway behavior or a gateway drug? Does one drug use lead to the next? And is that for everyone, or is that just for people who have a genetic predisposition to become a person who has an addiction disorder? Also, we want to start thinking about the legalization of substances? Do you believe all substances should be legalized? Do you believe marijuana should be legalized? Why marijuana and not other substances? How do you navigate around that if you're an employer? Also, if you're a counselor, so if it's legal for you in your state and you participate in the use of marijuana, at what point does it become abuse or a disorder? And then how does that impact your ability to counsel other people who may be trying to stop using all substances? What does sober mean to you? Does that mean all substances? So no cigarettes, no energy drinks, no caffeine? Or is that just sober from illegal substances? And that can change depending on what state line you go over. And then the other final thing I'll leave you with is think about trauma and think about how that impacts people and how people cope with trauma. I went to a training, I don't know, maybe a year or so ago, and it talked about it. Well, their idea was there is no addiction. Addiction is just a symptom of trauma. So everybody that has an addiction disorder has some sort of trauma, and that is how they've coped with the trauma. So if we treat the trauma, then we won't have the addiction issue. Therefore, addiction isn't even an issue, which was kind of an interesting concept and something for you to think about this week. So I'll go ahead and stop there with your food for thought. But make sure you continue reading your chapters, watching your videos, looking at your resources each week, and I'll be in touch soon. Bye.